Good afternoon. You've already met me today. I'm Flora, I work at IBM, Design Director. This talk was called something slightly different on the agenda. The reason it's not that is because the NHS comms team recognised the political importance of the NHS app and didn't give us approval to say all the things we wanted to say specifically about it. So instead, we're going to talk slightly abstractly about national scale health services, if you get my drift. So yeah, that's what we're going to talk about today. So I'm Flora, this is Sarah, we work at IBM, talked about that already. So we're going to talk a little bit more about not just the clinical safety part, but actually what we do. And what we're going to try and do today is give you an idea of some of how the best practice principles that we all know and love about design, we've learned we have to slightly amend or do slightly differently in the context of particularly national scale programs when we're thinking about health. So that's kind of what we're looking for. We're going to be talking about two different areas. So I'm going to talk about how those principles apply for kind of designing for patients and the public in really large populations. And then Sarah's going to talk a bit about how we apply kind of best practice design, teamwork, design ops, in that context as well. So a bit about designing for patients and the public and a bit about designing for the teams that we work with and our wonderful design teams. Bit of a wrap up and some questions. So Abby did a great job of introducing some of the clients we've worked with earlier. I wanted to do a bit more of a specific list to talk about the clients that Sarah and I personally have worked with in design. So lots of NHS on here, NHS obviously being our enormous national scale health provider in the UK. It is government funded. It is for every single person, not just citizens. This is why we say public, not citizens. Lots of people who are not UK citizens use their services. NHS screening, so big screening programs trying to find things in people before they go wrong. Obviously, test and trace and all of our COVID response was an interesting journey, and the NHS out for a minute. Genomics England, so genetic care through the NHS. It's kind of its own organisation, looks at research. We designed a whole bunch of stuff for them for cancer, really interesting. GSK and some other of our kind of pharma clients, and then some that are slightly more on the fringes, so Boots, which is a large pharmacy. The UK does a lot of kind of high street style healthcare and health advice. We work with them. Department for Work and Pensions, that's our security in England. They administer a lot of benefits based on people's health to help them if they've got disabilities or are experiencing long-term conditions. Same for Scotland as well. And then I did a really interesting bit of work with the European Commission as well, looking at rare disease platforms to bring, if there's 3 people in Greece who have this very strange variant or very strange disease, and their doctor doesn't know what to do, but actually somebody in Italy or somebody in Sweden has treated it before, how do we do that data sharing in a way that's really safe? So, fascinatingly interesting stuff. And these are some of the big kind of national programs that we've looked at. Obviously, the one we wanted to talk about in depth, and we will use lots of examples from, is the NHS app. So this app started about 5 years ago. As IBM, we started helping the NHS with it about a year ago, almost exactly. There are 58 designers on this team across 10 squads. I am one of the 2 design leads, because 2 of us, because there's so many designers that we have to look after. Sarah is our interaction design lead and kind of leads our design ops squad as well. It's the #1 app in UK healthcare. It has over 32 million users, and people use it for things like booking appointments, seeing their test results, getting information, getting access to national health services, possibly even the hepatitis C one that was mentioned yesterday. I was trying to work out if that was available through it. There's over 30 different services that are integrated. So this is the kind of scale that we're going to be talking about these design principles through. So for no further ado, design for patients and the public. Hopefully everybody knows what this is. This is a normal distribution curve. When we look at populations in science, pretty much everything that we can track can look a bit like this. And so we can assume that a population of a country, when we think about a certain attribute, will probably look like this in terms of its distribution. There's loads of people that will have kind of a middling thing. And there'll be less and less people as we get really specific on the axis. So people that do or don't have that type of privilege, that type of condition, whatever it is we're looking at. When we think about national scale services, when that population size isn't 100 million, 50 million, 100 million, what we have learned is that whilst we're designers and we want to design for everybody, actually 80% roughly of our effort needs to go into understanding the needs of the people at the fringes of this, which is a difficult thing to argue for product managers and people who look at our research plans and go, why? Where are like the normal people? They're like, no. If we design for the edges, we catch the people in the middle too. And I'll go into a little bit more. So why is it important that we focus on the people on the edges almost more so than the people in the middle? We're not being proportionately representative of our population. Because we might have a user, but when we think about health services, in particular, those users can change a lot. They can have all of these combination of all of these things. They might just have one, they might have all of them. That would be really difficult. And they push people towards the edges of that normal distribution, and they make life more difficult for these users. And we want to make sure that whatever we're doing in health, where you don't have an option in the UK, you just have one provider, if it doesn't work, you have nowhere else to turn to, that we have to catch the really complex combinations of these needs. So so when we think about test and trace, for example, one of the programs that we worked on for the NHS, we knew that we needed to collect information about people. We needed to find out where they think they got it, where have they been, who have they come into contact with. That's called a case, a person who has COVID. If you are a case, a person who has COVID, the NHS would ask you to fill out lots of information. In fact, we counted them. There were 97 different questions that we want that the UK HSA, which is the part of the NHS or the part of the British government that looks at pandemic preparedness and trying to keep people safe, that they wanted 97 different pieces of information. And that assumes that you only went to one place in the last 2 weeks. Obviously, you might have gone to 15 different places in the last 2 weeks. Don't even know. Now, that's already kind of ridiculous, but there's an element of kind of that's the business process, that's the policy we have to do. Fine, we tried to optimize that. But when you layer in the fact that people are maybe stressed because there's a freaking pandemic happening, they might be caring for a loved one, they themselves may also be ill. If you think about 97 questions, that's a lot of information. You're going to have to go back, look at your diaries, who did I see, what's that, like who was I talking to, who was at that event. It becomes a really complicated thing. But if you think about it in terms of the single user, they become a lot more complicated, and they also change over time. People get sicker or get better. And a lot of the health services that we are trying to put out into the world are trying to make change. So the experience of your user is going to change over time. You're working on an app to do with maybe mental health and depression, and it's maybe a medical device that's trying to help people. The user who signs up at the beginning, hopefully, we've done our jobs, not the user who then realises they no longer need the help of that app at the end because something has changed, better. We like this. Sometimes our services, however, are where people are getting sicker. Like if you've realised you've got COVID and essentially your symptoms are getting worse. So, first principle of the 4 is design for the edges of your population first, not the middle. We know that we should think about our whole population, but design for the edges first and design for changing states. Don't assume that they're going to stay the same. I'm trying really hard not to just say do good design. I'm trying really hard to say do design in these really specific contexts for national healthcare. That's number 1. Number 2 is kind of links a bit of this morning's clinical safety presentation, but it's like healthcare. It's not e-commerce, not a game. We're not trying to help people get from A to B on a transport link like logistics. It has really big consequences if you get this stuff wrong. We talked about that a bit earlier. We need to take what we do really seriously, and we need to help others to take what we do and what they are doing with us really seriously as well. So if we think about chatbots, for example, don't love them, but chatbots, one of the principles of kind of good design for chatbots is you never have a dead end. You always have kind of a ripcord you can pull or an escape hatch that helps you get help from a human being. I absolutely look at kind of national scale services the same way. There is no way that we can ever just end by going go to a help page. That's not how. That's not people who are ill who need help. That's not good enough. There we go. There must always be somewhere to turn for help, and in those scenarios, we've learned it's best not to think of your users as the one little person. In fact, pick the absolute worst scenario that your user could be in, and design your escape hatches for that. So it might be representative of an incredibly tiny amount of your population, but when that one person has that escape hatch they need, it's going to make a huge difference for them. It might also make a difference for the next chunk of people who didn't need it, but it actually was really helpful, and maybe they would have gotten help faster, or not had to deal with what they were dealing with for so long or so severely as a result of that escape hatch being there. So an example of this is, let's say like Apple App Store ratings, right? That doesn't feel like it's particularly close to clinical safety. Big gap between them. But we discovered in one of our services that people would, because of the way that it was kind of set up through the information architecture, that people would kind of follow this word, help, and feedback. I want to give feedback. What we were looking at as a design team, people would be like, oh, there's a bug here, it didn't work, I really like it, like it didn't fit it. UX feedback. What we were getting, trigger warning, was suicide notes. This is not good, because that was the last port of call for people who just were like, I'm done. It's too much, I don't know where to go for help. So they were leaving it in a space that we were looking to get UX feedback, which was mad. We've been looking at redesigning this recently, and we're kind of re-questioning everything, including the information. But when I was talking to the designers about how do we have to think about this problem, we have to always think about this problem from the absolute worst thing that can happen, which is at that point where they have nowhere else to turn to, and unfortunately a free text box is their last port of call. So we have to design it very differently from if it was just a normal kind of bit about feedback on like an e-commerce website. But maybe the worst thing that happens is somebody's really annoyed their package hasn't showed up. They want to deal with that. We're in a very different space in health, and particularly in like national scale health. So design for the worst case scenario. Principle number 2. They're dark personas, but they're not dark personas like hackers. They're dark personas like your user in their absolute worst state. Design for that. It's going to make it better for everybody. The third one is when we think about health, I think we all have pictures in our heads of doctors, nurses, healthcare professionals, people in hospital, people in GP surgery, people at family doctors. What makes it, again, more complicated, particularly in national health programs, and particularly in the UK, where the NHS is actually a brand and it's about 400 different organisations that don't talk to each other or use different data standards or have different standard operating procedures. It's all hidden. It's the same colour of blue and the same 3 letters, but other than that, it's a huge, diverse landscape. Is that the patient, we might think looks like this, but actually, I was trying to find a picture of the same person, that they're all different. They may be in a hospital, but they may also be experiencing like care at home. They also, at the same time, might be getting outpatient care or advice. They might be getting care in some kind of group scenario. They might be getting care in, they might be getting regular kind of blood draws and kind of going in for short outpatient procedures or potentially like specialist clinics. They might be managing their care themselves and kind of collecting data they've got to submit. And they might be getting other types of medical support, physiotherapy, chiropractic, whatever. It's a really complicated landscape, and I think we had stuff earlier about kind of the jungle of healthcare, and it's absolutely what it is. So the problem is, I think a lot of the time, that this is really complicated, and we're trying to often create another thing that goes into this landscape. Or maybe we're trying to simplify it, but maybe if we're trying to simplify it, we don't manage to catch all the different boxes, all the different stages of their experience. And when we don't manage to catch them, and we don't manage to make it all fit together, so who's the person who ends up carrying that burden of connecting it all? Normally, it's the person who's sick, the person who needs care. It's adding like another thing for them to do. So we try very hard to not make their lives more complicated than they need to be, trying to help them connect things up, and whether that's as simple as just using the same word as another organisation who are giving them care elsewhere, so that they don't have to kind of mentally translate, is that reference number the same as that ID number? I don't know. Trying to put it all together because they're already ill, they're already for some reason in need of care, so make it harder. So design for the full care pathway, from the moment somebody realises they might have something that needs support, all the way through to, sometimes it's, yeah, great, cancer-free, don't need to worry about it. Sometimes it's, yeah, course of drugs, I'm fine. Sometimes it's a chronic condition, and it will be with them their entire lives. You need to design for the full thing. So that's principle number 3. And then principle number 4. So this is us, kind of, designers, being excited. We love starting projects and looking at new problems and thinking about what could be, you know, the possibility of change and trying to identify those pain points. But what I've found is often, if we follow kind of normal design methods, the point at which we're getting excited and putting all the post-its up on the wall, we're not thinking about adoption. We tend to think of that later on in the process when we know what the thing is, and we're like, okay, we've got it, design's done, dev's building, we're testing, it's fine. Now what happens? How do we get it into people's hands? Related to the previous point about kind of the full care pathway, because it's so complicated, we found that we have to think about adoption literally from day one. So it's not just what are the pain points, who might the users be, but where do they find out about this type of help? And how do we make sure that we're building the very beginning, whether it's something that they're prescribed, maybe it's like an app that gets prescribed to them for digital therapeutics, maybe it's access to a type of support, it's bringing that question and asking about adoption from day one, the same that you might about research pain points, regulations, clinical safety, all of those things. So it's just bringing that way earlier in the process than we might do in other places where people's adoption is often, oh, I found an app, that's cool, the marketing team. It's nowhere near that simple in healthcare because it's part of this complex ecosystem. So designing for adoption is principle number 4. And I've talked too much today, so I'm going to hand over to Sarah to talk about designing for your design team.
Hello, can I be heard? Yes,
Might turn that one off.
Okay, perfect. So I'm going to talk about an entirely different side to what Flora just took us through. Which is how do we actually do all of that good design and who's doing it and how do we organize them and enable them to do their best work for those patients in this complex landscape of national health services, which other people might describe as design ops. I'm basically a massive design ops nerd. I have been for a long time. So I will take you through some of our design ops focused learnings that we've had over the past few years. So you can break down design ops into lots of different areas. People break it down in lots of different ways. But I'm going to talk about 3 distinct areas. First one being people. So our actual designers and researchers. How do we enable those teams? So something that we know, so kind of a fact, is that clear structure in our teams and responsibilities are important. And you could say that for probably any team trying to achieve any goal. And something that we've kind of picked up in this designing for national scale health services is that embedding design ops at the beginning to match the scale of what we're trying to do, what we're trying to achieve for our patients or our clinicians or whoever is really, really important. So what does that actually look like in reality? So these are 2 examples of teams that we've built and worked within for those clients that Flora showed at the beginning. So on the left is teams that we set up to work with Genomics England. So designing quite complex decision support systems in the world of genetics, very complex landscape. And on the left pillar, you can see we've got a design team, and we actually called it a design and discovery squad. So we had technical people in that team working with us because we're working with insane data. And if we're kind of describing it in an agile sense, it's probably most similar to dual track agile models. So our design and discovery squad are working ahead of those delivery teams. So we're going through, talking to our users, understanding what they need, designing solutions to solve those needs, and then feeding that into our delivery teams to actually bring to life. That was kind of probably a medium-sized team and kind of project in terms of what we were trying to achieve. This over here is more similar to what we're doing at the moment on the NHS app. So this is, again, a model probably most popularly described as a Spotify model, where you have those cross-disciplinary teams. You have design embedded in all of those teams, and those designers are working with developers and business analysts, product people on very specific parts of a product or service. So two distinct approaches, working well for kind of trying to achieve different outcomes. But how do we bring design ops into those teams? So on the left, in the kind of medium size, we had design ops individuals or people, designers or researchers within those teams that had ops responsibilities from the get-go. So they are in that kind of design and discovery squad, thinking actively about how we can optimize things for people and our design craft as well. Over here, and kind of this is where I sit at the moment, is the kind of a design ops team that sits around all of our designers. So it's a separate team that is kind of almost like hugging all of our designers and researchers and kind of enabling them to do their best work. And why is this important? It's important because of the scale, which Flora spoke about, and because of safety for our patients and users, and also because of the complexity of the solutions that we're actually developing. So thinking about how we operationalize design, and maybe the role of design ops is actually moving from model A to model B, and that's what those people are actively thinking of, not just how do we build the best product for our users. So moving on to the second area, which is around process, and perhaps another way to describe it is craft enablement. So how do we enable our designers and researchers to do their best work and kind of achieve principles 1 to 4 that Flora spoke through. And this is kind of traditionally what people think about when they think about design ops. So we have lots of repeatable tasks that we do. So we know that improving those, kind of making templates for things will improve the efficiency of our team so we can move faster, we can achieve our goals quicker, but it will also improve the quality of the work. And this is really interesting learning that I definitely wouldn't have seen coming, but building those artifacts and tools for your designers and researchers, you need to do with them and definitely not for them. So what kinds of things might you be kind of working on in the ops world? It might be patterns, so it might be things that exist in the design system, could be interaction design patterns, could be service design patterns that aren't necessarily digital. It could be building repositories, so pulling together all of our user needs and findings into one place, allowing that to be searchable, allowing people to use that aren't just designers, that are also product managers that can drive prioritization. All these things are very valuable, and also templates. There was some talk about templates yesterday. I think that work might soon be done by Gen AI and not an ops team soon, which I'd be happy about. But I guess when you're thinking about creating these artifacts and tools, there is quite a fine balance that you need to strike. So we're in quite a valuable position where we have an entire ops team who are focused on this work. And it'd be quite easy for us to say, okay, you guys focus on the product or service, and we can go ahead and make things better for you over here. And let the team do their work. But also what you need to do is get the team's input on those tools, because if the balance goes too much in the wrong way, so if you're off in a corner in isolation, building that user research repository, which will hold all the needs of your patients or users, you may not be understanding your team's needs fully. And your team probably are the ones who are speaking to the users every day, probably not you if you're like a full design ops practice. So it's almost just actually practicing what we preach and using user-centered design. But also an interesting one is that we've seen is that you may get a lack of buy-in, and probably the best example of this is thinking about design systems. So if you have a team that is kind of in charge of a design system, in charge of creating it, maintaining it, and you don't engage everybody who's going to be using that in that work to do that, you may not get buy-in. And that is your design system fails right there, right? So if it's not going to be used, maintained, kind of evolving, then there's no point in doing the work in the first place. But if the balance goes the other way, and you're kind of leaning on your teams too heavily to kind of help you build those tools, then the work that they're doing on product or service could get deprioritized and the focus is in the wrong place. Sorry. So what we're attempting to achieve is to get that perfect balance where you're both serving your designers' needs and also enabling kind of them to focus on the actual products and services. Okay, so lastly, the last kind of area of ops that I want to focus on is about outcomes and value, and this is something that Vitaly spoke a lot about this morning. So hopefully I won't have to go too much into detail on measurement. But we know that measurement is key to kind of understanding our success and allowing us to kind of sustain that success as designers. And something that we've learned is that it's so important to understand your maturity before you begin to both improve and then measure that improvement and kind of hone it. So to touch on the measurement side of things, as I said, Vitaly did a really good job of kind of taking us through some quite specific measurements and methods that we can use to measure our designs improving. This is just one kind of framework that comes from Nielsen Norman called the REACH framework and kind of splits it into 4 pillars. So the results area is kind of you can basically insert Vitaly's talk into that, and that's all about are our designs kind of improving and doing helping our users to achieve what they need to achieve, and ultimately helping our patients through those care pathways. But everything else in that framework is all about our teams and how we're doing the work and actually measuring that. And that can be, if you're not getting those things right, then often that first one of results is also not right. So yeah, I guess it's almost just like a slightly different way to think about measurement. It's not just focused on completing that task or achieving those health outcomes. It's also thinking about how we're actually doing that and how our teams are they happy? Do they have the things they need to be able to do their job? But before we even start to think about measurement, we have to understand where we are. So what is our baseline? And that is, I guess, not just a baseline in terms of the kind of health solution that we're working on, but it's also understanding our team and where we are kind of design maturity wise. And there's lots of different ways that you could do this. So there's loads of kind of design maturity assessment models out there. There's absolutely tons. There's like papers assessing them all. But first place to start is just actually to talk to your team and understand what they need, essentially doing a bit of user research. And then, yeah, this is just an example of workshops that we've run. You can also do surveys, but to give you that understanding of where the areas of opportunity are, and also that will help you understand and then measure what you need to measure to understand if the ops work you're doing is actually having an impact on your team and also your products and services within the healthcare landscape. So, to finish, this is kind of, I guess, our advice that we'll leave you with, but I guess our point is that both of them kind of need to sit together. So in order to design for your patients and the public, you also need to design for your teams as well. And yeah, both kind of sit together. You can't have one without the other. Thank you.
Thanks for a great presentation. I really liked your principle around designing for the full care pathway. So I think there's like a lot of risk there where things can fall down. What I wanted to ask is, with that principle in mind, is there like services in the app that connects to GPs or maybe to do prescriptions? What the process kind of looks like when you got it to go from like, okay, we have this national service, to all these different GPs who probably use different systems, technologies and stuff like that. How did you go about making sure that your service ended in like those service providers?
That's a very good question. I would argue that we have not yet successfully done
great
this
difficulty,
with
yeah.
enormous difficulties. We've been on it for a year. It grew very quickly. You sound like you're from the UK, I'm guessing you saw it. And then our COVID passes in the UK, the things you had to show to get into concerts and get on planes, all were through that. So it kind of forced everybody to download it. There are 30-something services. I would argue that none of them have really hit that yet. Some of the new ones that we've got coming out, we are making a very concerted effort to adhere to that principle. But unsurprisingly, there's a lot of pushback from those other pieces of the care pathway that we're saying that if we're the digital front door to this, the thing that you offer us currently doesn't allow us to integrate with the wider care pathway, and we'd really like it if you could change the way that you're sending your data to us. That then creates a whole load of mess because no one wants to change. But I think what we've tried to do is try to explain the consequences of not doing that on the patient, because ultimately everybody in our entire ecosystem should be focused on better patient experiences, or at least we hope so, to try and get them to change. We're seeing some, it's just we haven't done it fully yet. Hopefully one day we can say, yes, the prescriptions was amazing, but we're not there yet.
And
Go ahead.
And we do have baseline criteria that we hold kind of service providers to. So we'll do accessibility kind of assessments, and we will do kind of design assessments of their service, and then provide recommendations. And there'll be ones that are very hardline. You have to change this in order to integrate with us. And if you don't want to or you can't, then you can't. But yeah, it's a fine balance because you can't ask them to change everything. Yeah.
Can I ask one more question?
Go for it.
Yeah.
More in the design ops. Do you find, because you had to manage those, did you have like way more technical people?
With the
Design system.
The piece you were talking about. Practice.
yes,
Yes.
definitely.
A lot.
Yeah.
Some really, really great BAs who have been very helpful in doing that.
A helpful bridge. Yeah. Yeah. Thanks.
I'll go collect it.
There you go.
Yeah, I've got a question regarding the managing of the team. Where do you set your goals? Where they come, like maybe all my directors.
So how to almost prioritize the design ops work?
Yeah, and maybe some tips. What works good?
Yeah. I think yeah, because your overall objective and aim is so focused on, but you almost need to treat it like its own project. So and prioritize it in that way. So almost developing your own prioritization methods for what will have the biggest impact or value to the users, i.e. the team, as opposed to doing it in a kind of methodical, rigorous way, as opposed to just doing what someone just asked. Yeah, and then you can point to that method as opposed to say, oh no, as opposed to saying, oh yeah, of course I'll, or and adding to your workload. So you can put it through your kind of prioritization method, develop, add it to your ops backlog, and then maybe all the designers need that in order to kind of work twice as fast. So then that jumps way up your backlog, and that's the next thing you pick up. But we work in sprints like kind of everybody else, and try to prioritize our work in the same way. The work happens slower, so quite strange as a designer. So I'm used to working super fast, and it took me a little while to change with people is always going to be so kind of higher numbers.
Sorry, I was just going to add, particularly on the point about people asking to do their Jira tickets, I think we're very lucky in that we are in a design ops team that has a junior project manager in it. So if people ask, well, first of all, we can differentiate between design ops and just like PM tasks of like, can you just do this for me because I don't want to? We're like, no, that's not our jobs.
Yeah.
We also wrote kind of job descriptions for what we do, so we shared those with the teams. It was like design ops. Not everyone knows what it is, but this is what we're doing. This is the results that we're being held to. And if the work that you're asking us to do doesn't align to what we need to do, then we're not the right people to do it. Which has also been a very helpful tool because we're constantly explaining what we do to people. And they don't always understand, but we teach them, we learn. You're very welcome. Anybody else got a question? No?
Thank you so much.